we all know, today we are talking about memory loss and dementia. And just to understand, the point of this conversation is first to understand that there are certain things that are part of our normal aging process and the others are part of an actual memory problem. How to recognize those early signs, when to seek help, how to seek the help, and how to support somebody when they have dementia. And the main thing is there's a lot of stigma, there's a lot of misconceptions around dementia. So we want to break those misconceptions. So as we get into this session, I'd like all of us to keep an open mind, a very open mind about what this entails, the dementia aspect of things, the dementia aspect of caring for somebody, everything around it. Okay, we can move to the slides. So what is memory loss? First, I want to go through how does the memory work? So basically, our memory is dependent on certain brain cells in our body and the way they communicate with each other, especially in the areas that are responsible for certain aspects of what we call our cognitive function. Cognitive function is basically the ability for us to be able to do things that we want to do and be able to be functionally capable of doing things. Now, there's certain areas in our brain that when the cells are not healthy for any reason, it will affect how they store information, how that information is, processed and used. So memory loss is when there's a problem with remembering that information that we used to be able to remember very easily. But that doesn't always mean that not being able to remember things is necessarily a problem. So when we talk about what normal memory changes with aging compared to a disease form, normal loss of memory is when you will remember things, but it will take you a bit of time, a little bit longer, a few issues here and there. But when it starts affecting the way you do things or your ability to function, so if you're forgetting to a point where you cannot meet with people, you cannot cook, you cannot bath, you cannot carry out your functioning, that's when it becomes an issue. So that's when you're able to differentiate the difference between normal memory loss and memory loss because of aging and disease processes. Next slide. So there are many causes of memory loss. And when we look at memory loss, it's not, like I said, always dementia. When somebody is under extreme stress or duress, your ability to hold functional memory becomes a problem. When I say functional memory, your ability to remember things. So you may notice when you're under a lot of pressure, you could be told something, and after a few minutes, you'll not have any recollection of it. That does not necessarily mean it's dementia. So severe stress and anxiety can lead to problems with memory. When you get poor sleep, your sleep affects your ability of your brain to remain healthy. An unhealthy brain will have a problem with memory. Depression, like I said, stress, anxiety, depression. Certain medications will also affect your ability to remember things.
Doc, we can't hear you. Doc, we can't hear you. We've lost you. We are calling.
The different causes will affect our memory in different forms. So memory is, like I said, a function of our brain, and it depends on three main things: the health of the cells, good supply of blood, and the communication between our cells. Now, different parts in the brain are responsible for different sets of functions. One is it will receive the information. The second will be it will store it. And then the third, it will retrieve that same information. So when the system is not working properly, and the reason I'm going back to the previous slide is so that we understand how the different causes are not always dementia. So when these things are not communicating in a certain systematic manner, it will start causing problems with memory. So you may start forgetting names, appointment, recent conversations, and things like that. So when that happens, that's where you know it's a disease process, not the normal part of aging. Memory loss on its own is not a disease. It is a symptom that something in the brain is not functioning well. Now, again, I want to repeat this, that some part of memory loss is part of the normal process. Because the brain is going to slow down, the communication will be slower, it will not transmit the signals as quickly as it would. So it may take a longer time to recall something, but you will eventually remember. So if that happens, it's something that you need to flag, but also keep in mind it's not necessary a sign of disease or that. Now, when we go to the causes of memory loss, but not dementia, remember, it can happen with conditions that are either reversible or treatable conditions, like the ones in the list that is shared. Sorry, sister, we can go to the next slide, the one we were using before. When it comes to any of these things, like for example, when you have poor sleep, it can't consolidate your memories. So you will have a problem with remembering things. When you have depression, anxiety, stress, any overbearing issues, they interfere with your ability to concentrate and store the information. When you have a problem with vitamin B, for example, vitamin B deficiency, it affects the nervous system, the nervous function. The same with thyroid disease, the same with dehydration. All of these will affect the way the brain is functioning. So the key message that I'm trying to create here is memory loss will reflect brain functioning, but not your intelligence or weakness, and not all the time that you have a problem with your memory is it classified as dementia. So we have to really, really look into reversible causes of memory loss before we start assuming it's something that is dementia. You can move to the next slide. Now that we've understood what happens with memory, how it's working, how it's lost, now to distinguish, the main thing is to distinguish between what is a normal aging part of a brain and how does that normal memory loss affect us compared to what we've just discussed about the different disease conditions. Why is it important? So when you have normal aging, you have a natural biological change happening in our body. And the number of brain cells always remains stable, but the connection between the cells becomes less efficient. Now, the speed where signals are, imagine an electrical circuit with a lower battery. It will flicker, but it will be much slower than if you have a really sharp new battery. Same thing. This happens because now the layers around your nervous fibers are reducing in the efficiency of communication between the neurons. Those are the nerve cells. Now, there are mild age-related changes that can happen to what we call the chemicals in our brain called the neurotransmitters. These are key in playing a role with our attention, how we are able to focus, learn, and store these information. So as we go, the neurotransmitters are also becoming less. So, when you have an older person saying, I can think about it, it's on the tip of my tongue, but I can't really say anything. That's when you know these are normal memory changes. It's the retrieval of these memories that is slower. So normal, you'll have slower recall of names and words. You'll occasionally forget things, but remember them later. You'll misplace things, but you'll eventually find them. And the main thing is you're still able to carry out your activities of daily living, like bathing, grooming, feeding, and moving around comfortably. And they do not worsen rapidly. So that is normal memory changes. When we look at memory disorders, when you're talking about things like dementia, it is progressive damage to the brain cells. We can move to the next slide. And I hope I'm not going too fast for everybody.
You're fine, Doc.
Okay. If I'm too fast, please raise your hand and slow me down. So when we are talking about dementia, it's very different. There is progressive damage to the cells of the brain. That's why it's called a degenerative condition. It doesn't just happen suddenly and it's really bad. It over time deteriorates because it's over time, the damage to the cells is increasing, the ability to communicate between the cells is worsening. And this mainly in dementia affects areas like the memory, language, and what we call executive function. So in dementia, like for example, Alzheimer's dementia, there's a protein that accumulates in our brains, which will lead to the loss of the brain cells, the neurons in the brain. And then you have a chemical, the ones I mentioned, the neurotransmitters, something like acetylcholine, starts decreasing. And as the disease progresses, more networks in the brain are affected. And the person who's affected is not able to compensate. And this leads to what we call a progressive decline. So with memory loss, when it's disease related, it's a slow progressive decline. When it's very sudden, there's usually something organic going on, like a tumor or something that can probably be reversed. The main thing to understand is in disease condition, it is progressively being damaged. In normal aging, the brain is still not damaged, it's just working slower. So progression and loss of function are very important warning signs to understand. Now we can move to the signs of dementia. The early signs particularly are of more importance. Why? Because this is what helps us recognize early dementia, because when you recognize it early, what happens is by the time you're finding out, you're in an emergency situation. So when we haven't diagnosed it early, families will delay seeking help. They will assume this is part of the just old age symptoms and not do anything to support the patient with dementia and make it slow down in progression. And the first noticeable changes that people find when it's dementia could be even in personality. It's not always memory loss that is the early signs. So first noticeable signs are personality, behavior, social conduct. That's even before the memory loss happens. So you'll know many times I get patients who come and tell me, we now know it's dementia, but when we started noticing it, the person wasn't themselves, they'd changed, they'd become more irritable, they'd become a loss of interest in their normal ways, and we just assume they're growing old and don't feel like hanging out. Now, when you have these kind of changes, there's a part of our brain called the frontal lobe. That's the one that regulates our emotions, behaviors, and personalities. So in certain types of dementia, these will be more pronounced than the memory loss. So the memory loss may come even much later or not even much at all. So it's very important to remember that dementia is not only memory loss. So when you're looking at it from my perspective as a geriatric practitioner, the behavioral changes are often the first clue we should be able to pick out, but we don't take them seriously up until the memory loss and somebody's really gotten lost or is fighting about not being fed breakfast yet. They've had breakfast every single day, or being told that they're not being cared for yet, you're with them, happens. So any kind of unexplained change in personality, behavior should always be a push sign to check that could this be an early dementia. Now, another very, very loud symptom of early dementia, it happens in, again, Alzheimer's mainly over the frontotemporal kind of dementia, is difficult with recent memory. So a lot of times I also have patients coming and telling me that, his memory is fine. He can remember what he did 10 years ago. He can remember exactly where we went on holiday. But we tell him that we had a visitor yesterday and he can't remember. So as a family, you're very confused because he can remember things that everybody else has forgotten. But what he was told this morning is hard to remember. And that is why recent memory is what is important to notice when you're looking out for symptoms of dementia. And this is usually, again, one of the early signs along with the personality changes, because the first brain area affected in many dementias is the area we call the hippocampus, which is responsible for forming new memories. So that area gets affected first. And that's why in things like Alzheimer's, recent memory loss becomes a very, very early sign. So the brain is not able to store new information as well as it used to. Learning difficulties also are part of one of the early symptoms. So somebody used to enjoy doing things and would learn and pick up new tasks, new skills easily, suddenly can't even remember how to do things they used to know and do every single day. That's, again, a normal sign. Again, a lot of times that happens with female patients. We get the family complaining that she loved to cook and now she doesn't want to go to the kitchen. And we just assume now she's tired of it. Why that is important to take as a red flag is because if a person was cooking comfortably, loved doing it, and suddenly has stopped, is it that they don't like cooking? Are they tired? Or is it when they're there, they're not certain what to do? And that's when you want to evaluate them for early signs of dementia and get a full checkup on their cognitive functioning done. A slightly later sign of it is when they cannot manage their finances. So you'll hear loss of money, paying people randomly, paying bills twice or thrice, forgetting to pay their bills, or leaving the gas on, things like that. That's your executive functioning. And again, language changes. A person who was easily conversing in 5 or 3 different languages suddenly cannot speak any of the languages they've been communicating perfectly and start reverting to a language that they haven't spoken for in many years. These are very, very typical early signs of dementia. So what the most important clinical principle is that early dementia is not defined by forgetting alone, but by progressive loss of function. When we are able to recognize these signs earlier, the diagnosis, the planning, and the support prevents crisis. You're not in an emergency situation where you're reporting a lost person or you find somebody who has lost so much weight that they're falling sick because nobody understood that they could have been having a cognitive impairment or a dementia happen. In many dementia diagnoses, there is a delay in the diagnosis because the early behavioral changes have been usually dismissed by family members as part of either just normal aging or he's been under a lot of stress. So when should we be concerned? We should be concerned when these memory problems are persistent and worsening over time, when they start interfering with daily functioning, when other people start complaining about there being a problem. It's very important. The patient themselves will never notice. The patient themselves usually very rarely notice there's a problem. They will feel like you're making up a problem because they do not remember forgetting. They forget, but they don't know they've forgotten. And it's also important to be very concerned when there's a safety or independence issue at hand, where a person is now no longer able to take care of themselves. Now we come down to how to diagnose dementia. Dementia is usually diagnosed by certain structured guideline-based assessments. We have an international guideline for it, but unfortunately, that may not always be a possibility because of cost-related issues, a lack of specialities or skilled training, people who are skilled to identify these things early. But the initial screening and history remains a very important part where your doctor or your clinician will need to get a detailed history from both the patient and the family. Why is it important again to listen to the family? Because I said families don't have insight. They will come and tell you everything is fine. I'm just here for a checkup. And that's really important to identify because they can tell you, I don't forget. But the doctor who's brought them in is nodding her head in the background is like, that's not true. You ask them, have you had your meals? I take meals regularly. The doctor in the background is mouthing and saying, no. He's not been eating well. He forgets that he's eaten. Or he's forgetting and he doesn't eat. Something along the line. So getting both the family and the patient history in details is very important. And the areas you're focusing on is memories. So if you are taking your loved one for a checkup, please don't feel like the doctor is, prying into your personal life when they're asking very detailed questions about what did you do? How did you retire? When did you retire? Are you retired? How many children? How many houses you have? Because we're just trying to understand, is the information the patient giving the same as what the family knows? That is the way things are going. Then we go into what we call the cognitive testing. There are tools we use like mini mental state exam, a MOCA. And when you go and see your doctor, they will explain these tools to you. The tools ask a set of questions. They ask the patient to do a couple of tasks. They may draw something. Usually the most common is to draw a clock and put a time. And that is one of the first things that bring the red sign that, oh, you're asking my dad, who is a professor, to draw a clock and write 10 past 11. Are we back in nursery school? But when they start drawing it and when you're like, oh my God, he can't draw a clock anymore. And it hits you as the loved one in quite a bit of shock that, wait, what's going on? So even if you had any doubt, you'd be like, okay. So please don't get offended when your clinician asks your loved one, who may be in a very respectable very academic position to do things like name a lion and look at a rhino, because that is where the executive function, language, visuospatial skills are being tested. Then we go down to the physical and neurological exam. Why this becomes important is because you want to look at, are there any neurological conditions that are possibly happening that is affecting the person's ability to function, which is not at all dementia? Are they using any medications that could affect cognition or would, present like cognitive impairment? Then you want to check, are they moving? Are they able to move? Because social isolation and lack of movement contributes highly as a risk factor to dementia. So you want to make sure those are not existing. Then we come down to lab tests. Please take this very clearly. There are no lab tests for dementia. The lab tests are being done to rule out reversible causes that we talk, like vitamin B, vitamin D, thyroid, electrolyte imbalances, vitamin D deficiencies, dehydration, and all of these things, if existing and you fix them, the memory loss becomes significantly improved. Then again, it comes down to MRIs and CTs. You could have a perfectly normal MRI and still have a really poor scale on the cognitive assessment. So an MRI, again, is to rule out structural changes that may be contributing to memory loss, to rule out strokes, tumors, and other things that could be there. A PET scan is done. It's called an amyloid PET scan to determine if there is deposits of the amyloid protein that is a sign of Alzheimer's type of dementia. Imaging is usually to rule out other things. And just because you have a normal imaging report does not rule out dementia. Then you want to do the functional and behavioral assessments. The functional behavioral assessments are trying to assess the level of independence a patient has, what they're able to do when it comes to what we call the activities of daily living. And this is when early personality changes and behavioral changes are usually able to get documented as an early sign. So this is when we come to talking about what is the role of what we call a comprehensive geriatric assessment, a CGA. A CGA's role in dementia diagnosis goes far beyond the memory testing. It's going to evaluate your physical health, your comorbidities, your medications, nutrition, mobility, mood, social support, and the caregiver's needs as well. Because when you have a patient with dementia or a likelihood, you want to ensure that you have a holistic understanding of the older adult. You're wanting to identify reversible contributors to the cognitive decline so that even if it is a dementia, you're able to address things that will worsen the progression. And you're able to you create a guide of a personalized care plan, because this is a journey that is now going to be a lifelong journey for you as a loved one, you as a caregiver, you as a patient when you still have the ability to reason and understand that this is going to be a progressive condition. In this way, when you use the CGA as one of the most important tools, you get all the functions. So why is it important to do it stepwise and not just jump to tests and running after every kind of specialist? And because a lot of times when you don't do that as a family, it gets very frustrating. Patients usually are not cooperative, not because they're difficult people, but because they don't remember there being a problem. So even when there's a problem, they're like, there's no problem. Why are you creating a problem? So when you follow the guidelines, you are able to diagnose accurately. You're able to identify reversible causes. Families go through a process of being involved and feel empowered. And care plans are created well in advance before you are in a crisis management space. And this helps because it takes care of giving independence and dignity to a patient, no matter what the underlying diagnosis may be. Now we come down to a very important part, how families and caregivers can offer support. The main areas in these places are that the family and the caregiver becomes the central role in supporting older adults with memory loss or dementia. And whatever you as a caregiver are going to do is going to determine whether you're going to preserve independence, reduce anxiety around the condition, and improve the quality of life. So when we're looking at daily support, we're talking about consistent routines. When you have a consistent routine, you're making sure that the patient themselves have security around them. They feel less confused. There's routines for medicine, for meals, and bedtime. But what is important to understand that the routine that you as a person who's not affected with dementia is not the same kind of routine that would be able to be implemented for a patient with dementia. So you have to create a routine around what is their normal way of being. And their normal is not always the same. A patient with dementia's normal is not the same as a regular person's normal. So when you're talking to them, you must use simple, clear language. Do not talk to them like a baby, but you must speak slowly, give one instruction at a time, and you have to repeat in case they haven't comprehended. Sometimes when you use memory aids, it helps. Calendars, to-do lists, little sticky notes with little reminders, keeping a diary, they help engage the brain and also compensate for the memory problems that give the patient more independence. You want to allow what we call safe independence. Safe independence allows the person to do what they can safely and without any, where they're dependent without feeling dependent, so to speak, right? And that allows them to feel safe because you're able to govern what could be a risk to their safety and take that away. Then we come down to monitoring medications, finances, safety. A lot of time, a lot of financial abuse happens to patients with dementia. And what brings it to the family's notice is when there's been a lot of loss of money. And that puts the patient at a place where their safety is affected. So it's good to be able to identify that so you're able to support them without taking away their independence. Always remember, people with memory loss can feel very frustrated, anxious, or depressed. So when you respond, please respond with patience and reassurance. Avoid arguing over forgotten facts or things they've forgotten. Don't keep telling them that, oh, you told me this, or I told you this, and you don't remember, because they genuinely do not have any recollection of that moment. The main other thing that improves and how you can support yourselves and the patient is social engagement, participation in hobbies, creating new hobbies, involvement within the religious and community activities, interactions within family and friends based on how their moods is important. It's also important to screen for depression and anxiety or social withdrawal because sometimes they are overlapping with dementia, but they're not being treated, which worsens the dementia. And a very, very important aspect is caregiver well-being. I cannot strain enough because when the caregiver is not well, the patient will definitely deteriorate. Because caring for somebody with memory loss can become a very, very difficult thing. It can be very exhausting. And you as caregivers need to seek support, whether it's through information, through professional guidance, through counseling, taking a break, going into respite care for the patient may be important. And when you're able to put these together, they help maintain dignity and quality of life of the person with memory loss. And it also at the same time reduces anxiety and stress for the caregiver, which allows care to be optimum for the sick person. And this also allows independence, not only for the family, but also for the patient themselves. Do we have any questions this far before I go into advanced caregiving principles?
Yes. There is one person. Ruth, go ahead.
So I'm working in an institution where I'm looking after patients with dementia and learning disability. What I've observed is anytime they become anxious or agitated, the first investigation is do urine test to rule out UTI. Why not start with any other infection? Because we know infections can make them more anxious. What's the relationship?
Okay, I'm not sure why they only do a urine test first, but we must remember older adults are more prone to UTIs. UTIs and urinary tract issues are part of what we call the geriatric syndromes. The geriatric syndrome is things that happen more commonly in the older person space that is actually not the real problem, but an underlying problem to other things. So older persons go through constipation a lot. They have a lack of mobility. And because of those things, they're more prone to UTIs. And UTI is one of the most common infections. And I believe that would be why, I cannot explain fully why the institution you work at does that, but that would be one of the justifications in my opinion. However, having said that, I believe in case of any change in the behavior of a patient with dementia, which we will get to, it is important to rule out all infections. So a basic blood count and a CRP plus a urine becomes important because it could be any infection. So just because you have a normal urine test doesn't mean there is no infection elsewhere.
Thank you.
I hope that answers you. Now, I'm going to go into what we call advanced caregiving principles. The reason I took a break between the others and now, when we get into advanced caregiving principle, it's more involving, more skilled. And that doesn't necessarily mean a person who's not gone through a training can't take these skills and involve them into the daily care aspect of the patient. So the key caregiving principles that reduce stress and behavior problems in people with dementia is, like I said, to avoid confrontation and infantilization. That is basically when you talk to a patient with dementia like they're a baby, because some of them need to be spoken to and the others at most do not. They actually get very offended and do not comprehend why they're being talked to like they're a 2-year-old. You're expected to talk to them like you would a normal person, even just slightly slower, slightly louder, maybe repeat what you say, but do not talk to them like they are children, because that will increase agitation and fear. When you argue or when you're correcting them, you're doing it very harshly. It's like you're trying to tell them something that they cannot possibly comprehend. It's like if you can see a color yellow and I try to convince you that that is blue, you are honestly going to think I'm the one who has lost my mind, because you are seeing yellow as yellow, and that is what your brain is telling you. So when I'm arguing with you and telling you that the reality is this is blue, you are genuinely going to think there's something wrong with me, however true I might be, because your brain is comprehending something that it is telling you, and that is your reality in dementia. So you can't expect them to accept reality. But it's also important to involve them in a decision. You may know that they can't give you the correct decision, but it's important to ask them, would you like to have a glass of water? Would you like to brush their teeth? Chances are they may say no. And you'll still brush the teeth somehow, but you need to keep them involved because they still have to preserve dignity. You don't want them to make them feel like they have no value in life and they're going to be told to sit, stand like a robot and they're expected to do it. You need to learn how to be firm, but with supportive structure and activity. Firmness is important because a lot of times they will not want to do what they're expected to do. So you have to be firm about maintaining routines and activities, but firmness does not equate to forcefulness. You have to find ways of making sure it happens through gentle firmness, because the reduction in activity or inactivity worsens the condition. It will worsen confusion, behavioral problems, and routines does not mean if they're waking up at 10 and they have to have breakfast at 10, it has to be 10. They may wake up at 10 and decide lunch is breakfast and breakfast is lunch. That's perfectly okay because their routine is not a strict schedule. Setting routines with patients with dementia equates to where you have a familiar, predictable, and repetitive cycle happening. It's not really about 10 o'clock is breakfast time, 1 o'clock is lunchtime. It's about knowing a meal has to be provided, and this is how the meal cycle is going to go. Giving something we call good daytime activities will help prevent sundowning syndrome, which we're going to discuss next. We'll get into that. Then the other part is the kind of games and memory enhancing activities. You want to encourage activities that will stimulate the brain, but are not stressing a patient out. So trying to give them things like complicated maths sums to do may actually cause more damage than giving them a grade 1 maths book to do, because that won't stress them. But if you try and give them a high schooler's book, it will stress them out because they can no longer do it. Simple card games, board games, or puzzles. Sorting out objects, sorting out games, word matches, looking at old photo albums, listening to old music that they resonate to, reading out aloud to them or them reading out, singing with them, storytelling, giving them light household tasks like folding clothes or watering plants or planting. So the aim of this engagement is not how the outcome of the activity is. It's about engagement. It's not about the performance. When we get patients who may be agitated, the main things to remember is to speak slowly, softly, and calmly. You want to reduce background noise and distractions when trying to calm them down. Maintaining eye contact remains very important when trying to calm them down. It helps them feel a little bit more reassured. And you want to direct their attention from what is stressful to a different activity that could be happier for them. So if they were playing with blocks and it starts stressing them out, you want to redirect them to something that calms them down again. And you may be able to ask, sometimes you may get an answer. Don't always assume if you ask a question, you won't get a legitimate answer. You should ask, what is causing the distress? You may actually just be given a simple answer. Remember, patients may not recognize pain and discomfort easily because they are not able to express it. So how do you recognize pain or discomfort in a patient with dementia as a caregiver? You want to watch for signs of restlessness or pacing that is not part of their normal. The facial grimacing or guarding, they get really touchy about the area that's tender. They may suddenly get aggressive or withdrawn. They may refuse to eat or participate in things they were normally doing. And these are really, really important to identify as behavioral patterns to identifying discomfort or pain in patients who may not be able to communicate their intent. Common causes of agitation in patients with dementia are things like pain, constipation, urine retention or infections, and hunger. Now, in our area in Kenya itself, it's some of the things we can be using to give a better care space is good lighting in the house, removing obstacles around our house, simple doors that can lock to prevent patients from wandering and getting lost, identification cards or bracelets that in case they're roaming around the compound and can't find their way back, somebody in the compound is able to identify where they're going. Keeping supervision when they're walking outdoors rather than not allowing them to go. And basically, your way of safety should not be through restriction, but through environmental adaptation to the patient's condition. Restraining only worsens dementia. When we want to look at nutrition, you want to look at both under and over nutrition. Dementia patients often overeat because they've forgotten that they already had a meal and they keep asking for a meal. So you need to remember that these are things you want to look out for, the subtle signs. Undernutrition can come around because of poor appetite, forgetting to eat, difficulty with chewing or swallowing, dental issues, depression. So you want to always make sure you are looking at the patient as a whole. Just because you're focusing on the dementia, don't forget they can still get a dental issue. They can still have a gastrointestinal problem. So remember, other causes of problems with feeding is not only because of the dementia. Identify them and correct them. Again, overeating can happen from repetitive eating. The patient's ability to know that they are satisfied when it comes to food or satiety is poor. So they may not realize they are full until they've overeaten. They usually have a preference for sugary foods, so that will lead to overnutrition. So how do you manage this is regular meal times, small frequent meals, supervision during the meal so that they don't get burnt or don't get hurt, monitoring their weight regularly. So when you're looking at dementia care, you want to look at nutrition, routine, safety, dignity, meaningful activities, because these are equally as important as any other medication or medical guidelines you may be using for dementia care. Now we go into sundowning. What is sundowning? It's a syndrome that refers to worsening of the confusion, agitation, anxiety, and behavioral problems that happen in the evening. So a person could be very calm the whole day, and as soon as evening starts setting down, they start getting more agitated, anxious, confused than they were at all during the day. And this is a very common and a very distressing condition, both for the patient and the caregivers. Why does sundowning happen is because there's a disruption of our brain's normal rhythm in dementia. Our internal clocks that will regulate our sleep and wake cycles is disrupted. And this happens because of the way the brain is responding. So when you have dementia, there's a degeneration of these cyclic things. So your sleep-wake cycles, your attention and arousal cycles, your hormonal rhythms like melatonin secretion are affected. So when that happens, your normal rise of melatonin in the evening is disrupted. Your brain is not able to distinguish night from day very easily. So you're more agitated because you think it's day. The brain is responding to daytime, and here you're trying to calm a patient down for the evening. Now, by evening, sometimes patients, when they go through sundowning, could be as a cumulative effect of mental fatigue from previous days or from the morning. If they've been overstimulated during the day, they can lead to sundowning. If they're understimulated, they will still lead to sundowning. So you have to find that balance of what is just enough for this particular patient. When I say this particular patient, it means what works for patient A will not necessarily work for patient B. How do you help? You help with these things by making sure that a patient who is, going through sundowning, you're able to identify the triggers. So what are the triggers of sundowning? Fatigue and sleep deprivation, hunger or thirst, pain, constipation, urinary issues, infections, too much noise or activity, poor lighting and shadows, and changes in routine. These are the more common triggers of sundowning.
Yes.
So if you can identify them, you can help them. How do we prevent it? Most of the time, the prevention or management of sundowning is non-pharmacological. By maintaining structured daytime routines and regular activity with a routine and exposure to daylight will reduce sundowning. Encouraging physical and mental activity in the mornings and early afternoons rather later in the evening. Avoiding daytime naps is really, really important because that's why they get confused and get more agitated in the evening. During the daytime, make sure they're exposed to bright light and adequate lighting in the evening. Keeping the evenings calm, quiet, and predictable where it's, again, routine plays a big role. You want to reduce noise and stimulating behavior late in the afternoon. Then, of course, you want to make sure regular meals and hydration, that you're taking care of any underlying issues like pain and constipation or the urine issues. Now, for example, despite doing everything, a patient still remains agitated. How do we help them? You reassure calmly, you redirect to familiar and soothing activities, avoid restraint and confrontation. It's important to understand that sundowning is not a psychiatric problem. It's a physiological and environmental problem. More often than not, there's something going on within the person's body or around them in the environment that is causing them to get more agitated during the evening. So it's not always a problem that needs medication. So managing routines, light, the exposure to light, managing their activity, managing their sleep and comfort is far effective than starting to put them on sedative medications to calm them down. Now we go into a very important part of this conversation about the myths and stigma around dementia. Some of the most common myths is, as you can see, the dementia is a normal thing. It happens to everybody who's going to go old. Nothing can be done to help. As much as dementia doesn't have a cure, there's a lot we can do to provide quality of life for patients with dementia and slow down the progression of dementia. People with dementia can have a very good quality of life, maybe an adapted quality of life, but a quality of life nonetheless. People should manage dementia alone. It is very important to understand it takes a village to raise a child, and it also takes a village to care for dementia patients, and it also takes a village to care for an older adult with or without dementia. The thing about dementia is you want to understand that there is no shame in seeking help. You shouldn't be worried about seeking help. And dementia is not a contagious or shameful condition. It's a condition that occurs and we must know how to manage it. Now we go on to why does stigma around dementia exist? Because of the fear of aging and dependency is one of the biggest reasons for stigma. A lack of understanding of brain disease, cultural beliefs that are linked to dementia, which are like, that it's a curse, it's a punishment, the shame associated with the loss of independence and disability. The belief that nothing can be done leads to a lot of stigma. In a lot of communities in Kenya as well, dementia is usually not recognized as a condition. It's actually identified as either normal aging, witch crowd, spiritual issues, family disgrace. And because of this leads to silence, denial, and a delayed care plan or delayed action. And stigma harms both the patients and their families. Dementia causes a lot of complications, either malnutrition, other issues, harm, financial loss, and that's when you're reporting when so much has happened that could have been prevented. Missed opportunities for early diagnosis. With the stigma, there's a lack of caregiver support. The patient ends up in social isolation, which worsens the dementia. There's increased caregiver burnout because of stigma. And then hospital admissions because of crisis happen where you could have avoided it. Dementia is a difficult disease. It does affect memory, behavior, personality, independence, family relationships. But please remember, the truth of dementia is it is not hopeless. With the right interventions at the right time, we can do the following things. We can delay progression of the disease. We can reduce behavioral symptoms. We can preserve independence for a longer period of time, which will lead to improved quality of life. We can reduce caregiver stress. We can prevent crisis admission. And what happens when you intervene in a timely manner? You're able to treat reversible contributors, which again slows down progression of the disease. You're able to initiate cognitive enhancing medications when need be. You're able to educate caregivers and train them early so they're able to cope with the dementia as caregivers. You're able to make adaptations you need within the environment to prevent things like sundowning or environmental hazards that can lead to complications. You can go into what we call advanced care planning, where the will of the patient will be maintained in an emergency situation or in a crisis space. Studies have proven that early comprehensive management of dementia slows down the functional decline and it delays institutionalization or hospitalization by many years for dementia patients. It gives them a higher quality of life. When you have a late diagnosis, there's rapid deterioration of the dementia, there's uncontrolled behavioral problems, there's high caregiver burnout, there's a lot of emergency hospital admissions for nothing, there's loss of dignity. This is where I ask you as individuals who are listening in today to help all of us overcome the stigma. How? Education and public awareness. Understanding dementia as a brain disease, but not a failure on a personal level. Encourage early help-seeking behaviors. Supporting caregivers or family friends that you may know who are going through caring for a loved one with dementia. Inclusion of the older adults within the community life at any level possible, even with dementia. Talking about dementia openly without shame. Please let's remember dementia is not a curse. It is not shameful. It is not untreatable. Being untreatable and being uncurable is different. You may not be able to cure dementia, but you can definitely treat it. And treatment of dementia is through preserving dignity, care, inclusion, and ending stigma is almost as important as medication and the other care we give patients with dementia. Are we okay so far?
Yes, Doc.
Okay.
Yes.
How do we go around reducing stigma and promoting healthy brain aging? Why is that important? Healthy brain aging is not an accidental, like an incidental thing. It is a result of lifelong protection of the brain's blood supply, metabolism, and neural networks. So the most important driver of cognitive decline in Kenya particularly is vascular disease. So brain health is very dependent on managing underlying conditions like hypertension, diabetes, high cholesterol, smoking, because these things lead to small vessel disease and microinfarcts or silent strokes that are one of the bigger reasons for dementia in older adults. Now, we need to keep these, a lot of older persons don't care about their blood pressure. They're like, we're fine until something goes wrong. So aggressive control of BP, sugars, and stroke prevention is brain protective. It's promoting healthy aging. Physical activity, again, improves what we call the brain's ability to learn new things. When you're increasing your physical activity, you're increasing blood supply. You are increasing what we call BDNF. It is a factor that is neuroprotective. It protects your brain. And this delays neurodegeneration. Then you have your nutrition. So simple things, around the physical activity, daily walking, strength training, gardening, household work, within any society within our country is possible. It doesn't need fancy equipment or things like that. Managing the nutrition and micronutrients, vitamin B, vitamin D, iron, all these things are very important. Most of our population is at a high risk of protein malnutrition. So keeping a high protein diet is very important because it's healthy for your brain. Hydration becomes very important. So regular nutritional assessments are important to make sure that you're putting in place brain protective interventions. Managing sensory losses based mainly hearing and sight. Untreated hearing loss increases the risk of dementia by at least 5 times. And social isolation is very important in dementia as a risk factor. When people can't hear and see well, they tend to socially isolate, which puts on a lot of load on their cognitive spaces. So they're compensating for one sense with another. And it reduces the stimulation of the brain. And these are things that are usually not treated because of cost and access. So learning to provide or being involved in spaces where provision of hearing aids, hearing health, and eye health, please keep that, is as an important prevention strategy when you're looking at how to reduce the stigma and promote brain health. Mental health and sleep is very important. We cannot take away stress from our lives, but how we manage our lives plays a big role on how we're going to be dementia or put ourselves at risk for dementia. And diagnosing depression is very important because undiagnosed depression leads to far more cognitive decline than anything else. Social and cognitive engagement is one of the biggest predictors of your cognitive health. And why it's important is because it allows your brain to engage. Social and cognitive engagement is important. And how can we do that? Religious participation, allowing them to be a part of the community, you remaining a part of the community, intergenerational interaction, storytelling, reading, mentorship, grandchildren and time with grandchildren, family time, more than just the Christmas annual visits is very important. These strengthen the cognitive reserve in patients and promote brain aging in a healthy manner. Repeated infections and hospitalizations also work against healthy brain aging. So when you work on preventive measures, it's far better and it's far more important than actually waiting for something to go wrong and treating. So my greatest message here is that a healthy brain is achieved through good primary care, preventive care, chronic disease control, sensory health, mental health, and social inclusion. Prevention is one of the most powerful dementia strategies that we can employ when we are trying to, reduce dementia. Now we go into the pathways, when to seek help and pathways of care. There are red flags that require medical evaluation that we went through. We must know not to ignore those red flags. So families should seek medical assistance when progressive memory loss that is affecting daily life functioning and not just occasional forgetfulness. When a patient is repeatedly confused about time, place, or people, please take that as a red flag. Behavioral and personality changes, decline in managing money, not being able to take their medicine correctly, not being able to do what they used to do normally. Then you want to make sure that these are not people who are falling unnecessarily all the time, because falls are a high risk, and that gives you the red flags. When you have sudden or fluctuating confusion, that could be delirium due to many reasons and is not always necessarily dementia, but getting it treated and diagnosed is important. So this is when you need to go through an urgent referral. You need to, prevent rapid deterioration of the condition. And acute confusion happening is a medical emergency. So when you go through any of that, it's very important to seek help immediately and not assume it's just part of the normal dementia process. So how is the step-by-step pathway? You start usually at your primary care or family doctor. When you're at that level, that is the most important, because at that point, like we went through it, the detailed history will allow the primary physician or clinician to understand, is there something going on? They would be expected to do what we call a basic cognitive screening, even if it's not at a neurological level or a psychiatric level. It's important to get an idea, is there a problem? You want to screen for depression, sleep disorders, alcohol abuse, alcohol use, and make sure there are no nutritional deficiencies. Then you go down to doing baseline blood works that are the more common contributors of any issues would be related to your cognitive health, like discussed earlier. And at this point, you're able to identify many reversible causes. Then you want to refer, should there be something, if you're not in a position to know what is happening. You could refer when cognitive impairment is either confirmed or suspected highly, where there's a diagnostic uncertainty, or where behavioral symptoms are very severe. At this point, you may need to go through imaging and other issues. So the levels of referral could be through internal medicine, neurology, psychiatry, or imaging. An important part I can't stress enough, but we have resource limitation in this space, is a comprehensive geriatric assessment wherever it's available. It is one of the gold standards of evaluating an older person with any kind of problem, because it will evaluate you holistically. And it will look at your physical health, mental health, mobility, functional status, nutrition, risk of falls, mood and behavior, social support, caregiver support. And this helps in care planning much further. Also remembering that when you're looking to the step-by-step pathway of care for dementia, multidisciplinary care is important. The care is not on one doctor. It involves interaction on a continuous between the caregiver, the physiotherapist when required, the fact that there is the need of occupational therapists sometimes, nutritional support, counseling support, social support, and putting it all together. The role of the family cannot be undermined in the pathway of care. Families are not visitors when it comes to dementia patients. They are an essential member or part of this care team. And they are important because they are going to give you the timeline of symptoms, the behavioral changes. They will understand how to manage the patient far better than a medical person would, because they live with this patient and understand triggers and calming mechanisms that work for the patient. So the quality of history from caregivers remains very important when you're in the pathway of this care approach that you want to use. And you want to understand the importance of the early and continuous engagement of care. Care is not a once-a-year thing. It is a continuous monitoring, because things change very drastically, sometimes very slowly. So you need to be in continuous monitor. It's like you need to monitor and evaluate at routine intervals to see how things are going along. Are there any higher risk factors? Are things working as well? Or what you put into place working or not working, and does anything need any adjustments? So dementia care is not a single diagnosis. The message is it's a long journey. It's going to require early recognition, early and continuous change of care plans when need be, family partnerships, and a really, really strong support system. we're coming towards the end of our presentation.
We are good.
So to end today, what I need us to understand are the realities of our dementia care. We don't have a single clinical or perfect pathway in our country when it comes to dementia care. Most of our care is through private clinics or country or sub-county hospitals, faith-based hospitals, and consultations are really short. There's not much focus on the cognitive screening. Sometimes the ignorance around memory issues can be labeled as stress or old age. So it's very important to understand, despite all this, medication and medical treatment is not always the keystone. It is the early recognition, caregiver training, caregiver follow-up that changes how dementia is going to progress. Like I said earlier, dementia is not hopeless. It may be challenging, but not hopeless. When we intervene early, when it's consistent, when there's routine, people living with dementia can still live meaningful, safe, and engaged lives. Family advocacy is very, very important. So when you're a family, please bring in the written list of symptoms. Any small thing that you may think is insignificant, report it to your doctor. Keep in touch with your doctor on any small changes before they become an actual issue. Understand that, yes, as much as formal geriatric services are limited, most of our care in our country is provided by GPs, and keeping them in the loop is important. Most of the medications for dementia is symptomatic, not curative. And a lot of these drugs are very expensive and limited. So management is mainly behavior. We use behavior, environmental adaptations, caregiver training, and safety planning to support dementia patients and their families. Not because it is a choice, but it works equally as well as any other form of care. So once again, I want to reiterate, the success of dementia care is dependent on early recognition, family involvement, and consistent follow-up and dynamics in the care plan changes based on patient's condition and changes. I thank you for your attention. I thank you for your time. I hope I didn't bore you, and I hope this has been helpful.
Thank you, Doc. Thank you so much. Now you can air out your questions. Daktari is ready to answer.
Mine is not a question, but it's just a kind of input that I sometimes sympathize with our patients back at home, especially when cognitive issue comes in with the chewing and swallowing. You find they tend to hold food in the mouth, and we are not privileged that much that we do not have enough speech and language therapists who can assess and say what kind of food this patient is supposed to be given or this person is supposed to be given. So you find some of the nutritional issues are not because the patients have a problem. Actually, they have a problem, but it's because of just poor management, because once cognitive issue comes in, they cannot swallow, they cannot chew. Food tends to remain in the mouth, and this can cause a nutritional problem. And then another thing is because of what? We need to involve them. I'm very happy Daktari talked about it, that we need to involve the service users right from the beginning for a better outcome. Because if we sideline them and tend to do things for them, they get agitated because they feel they're not part of the program. But once we put them into the program, let them know this is what is expected of their care plan, then they become more involved and more interested and more active. Thank you.
Thank you, Ruth, for your input. Sister Christine, your hand is up.
I wish to thank Daktari for good work. That's a good work done. I have gotten a lot of knowledge. My question would be like, many are the times when I meet these old people, yes, we've talked of, we maintain a routine for them, But sometimes because of the mood change, now it could be now the time to eat and they refuse to feed, maybe time for bathing and they refuse. So, and now we are saying we may not force them, we just try to, but that thing of mood change, what would you really do? Because it happens, and if like if there are very many of them and the program needs to run, how do you do with that one who has just decided to refuse the food, refuse anything for that day?
Okay, the most important thing you said there is a program that needs to continue. I want to emphasize with dementia patients, you can never have a program that needs to continue. It goes by their way of dictating it. So if it's an unpredictable day where they don't want to bath or shower or do what they're expected to, remember, even as a regular person, you may wake up on a Sunday morning and just not feel like brushing your teeth just because you don't want to. That doesn't mean if somebody came and forced you, how would you feel? So keep that in mind with the dementia patient, that today they don't want to do something and you're making them do it by force. How would it feel? So the easier way to first try and identify if this person is usually cooperative, what has changed today? Is it the color of something has changed? Is it the way you approach them with a new caregiver? You need to identify why they're refusing first. It may not be very obvious, but if you look into options, you may find that it's easy to identify the change that has happened that has destabilized them from wanting to do what they're supposed to. Should that not happen, sometimes there's a fear attached to doing regular things. And when that happens, I'll give you an example. I had a patient who hated brushing their teeth. Like in the morning, brushing their teeth was a nightmare for the caregivers. And it reached a point where the caregivers like, she's just not brushing and we can't let her not brush, not because of anything, but dental hygiene. Otherwise she's going to have a problem with her teeth and she won't be able to eat, logically. So what? Only to realize her problem was never brushing the teeth. Her problem was going to the bathroom because the bathroom was a stressful space. Because when they brought a basin out and gave her toothbrush in the bedroom, she would brush quite fine. And it took a little bit of trying to understand why to find the solution to it. I don't know if that helps you, but usually the main thing is to identify why, what about it, and then you can find the solution readily after.
Thank you, Doc. Thank you, Daktari, for the good presentation. I would like to bring out my observation. Like somebody doesn't want to sleep in her bedroom. She wants to stay in the sitting room and she wants everybody to be there. I don't know what causes this fear. That is number one. Number two, you observe that this person is consistently doing quite well. Then like one day you are talking, you are engaging in a discussion and she brings a topic that is not related to what you are saying. All of a sudden, what causes such?
Yes, the second question. I didn't hear the last part clearly.
Yeah, the second one is this person has been doing quite well in terms of being fluent in a conversation. But maybe like 1 week she's doing quite well. Then all of a sudden you engage in a conversation and she brings something that is completely out of topic of what we are discussing. And you cannot really connect. So what causes such?
The main thing you have to remember is dementia patients' long-term memory is retained. And because of long-term memory being retained, sometimes you could be talking about something and the brain has sent a signal from that part of the brain. So they're actually living in that time again. So they're back in a space where we were having this conversation that to you is not making sense. And that is a very normal thing to happen in dementia patients. How you approach it is just have a conversation with them without highlighting that we're talking about something else. It's not really, just carry on with the flow, go with the flow. So if they're talking about, you're talking about how the beach looks and they want to talk about the forest, you start talking about the forest.
Okay.
That's the easiest way to go with it.
Thank you, Doc. Repeat your first question so that Daktari can answer you.
Oh, the first one was about fear of spending night in their bedrooms, and they want everybody to spend the night in the sitting room.
The
Doc?
thing with the fear of, the thing about fear of change of environment, you need, like I said, environmental adaptation is necessary. Sometimes you may have just changed the position of the bed sheet color, the lighting may have changed, something small, a change that you wouldn't even take, like, in your mind to consider that this is a big deal could have happened. And suddenly that person doesn't recognize their room as their familiar environment. The same thing that was familiar is no longer familiar. So please always be cognizant and aware that there are changes in the environment that could be a small thing to you and I, but they make a big role of impact on the patient with dementia's comfort. So a simple bed sheet color, position of bed, change of the color of the light bulb can make a very big difference on things you would never even keep in mind. So even the smallest changes need to be addressed.
Oh, thank you so much. Thank you.
Thank you. Regina, Sister Regina.
Okay, I want to appreciate Daktari for the good presentation. It's a good learning. And I want to observe some experiences. The previous person who asked questions, I think she touched one of my questions. You will find they get some fear. And I think it's the fear of unknown. They don't want to sleep. They don't want to sleep alone. And most of the times they are calling people to come around them. Thank you for also responding to that. But then another observation that I have made with the experience of different people, I have realized also for those people who have been soft in life, I mean, not soft per se, but they have lived a good life, happy, they are relational. Somehow it is easier to help them through than those people who have been rebellious in life. I tend to see like those people rebellious in life, they tend the rebellion against themselves at this time of life when they get in such a situation. And I think it becomes very difficult to help them. Just commenting is not a question because it's an experience I have seen, but if someone is able to respond to that, I'll appreciate.
Thank you. Thank you, Regina. Daktari will answer you. Meanwhile, there's a question being asked. Can young people also get this sickness, or is it only an old age sickness? And what about those young people who get the sickness? That's the question, Doc.
Dementia.
And dementia?
Yes, there is a concept called early onset dementia. It's a diagnosis that can affect people as young as even 40. The way it happens is the same as dementia in an older person. But yes, all young people can get dementia, and how you manage it is exactly the same way. But it's important to know that it exists. It's rare, but it does happen.
Thank you. There's somebody, Juliet, Sister Juliet, you have a question?
Yes, it's not a question as such, but it was an input on one of the questions that was asked by the participant on why some patients may tend not to fear to be left in a room alone. They want you to stay with them before they sleep, maybe with the lights on, something like that. At times, it's good to look at the history, the background of this patient or this person. Maybe they experienced a traumatizing event when they were in the room alone. So those moments, when they are left alone, it tends to take them back to such moments. And that's why they will always want maybe to be where people are, or when the place is noisy, they fear those quiet moments. So it's always good that us who are taking care of them to look also at the background, life, maybe childhood, things like that. There might be evidences of abuse or something of the sort that tends to throw them back to such scenarios. Thank you.
Thank you. Christine, you have a question again?
Yeah, okay, thank you. First of all, I would like to thank you for the enriching information you've given us. I have two questions or two concerns about the dementia people. First, I've interacted and been with these people with dementia, and what I've observed, there is this one who, like, especially at night, when the person is going to sleep, the person locks the doors and pulls the chairs, the tables to support the locking, like the person fears maybe something can get in or what. I try to ask this person, and it's like a routine. Every night locks the door and puts the chairs, sofa sets, and everything, at least to make sure that the person is safe. Another thing is the same person, anytime the person goes out or goes out of the compound, I've realized that this person always comes back home with, wherever the person comes across the nails or flowers, the person picks the flowers, and always when the person goes out, he comes to the same flowers home. And wherever the person comes across any nail, the person picks and brings it home. So I don't understand. Maybe if you can help me understand and the group. Thank you.
So for that,
Yeah.
you see, we have to understand that past history plays a very big role. If they've been through traumatic issues, traumatic spaces, those will play as a continuous loop cycle in their mind where they believe that is happening again. And those are called the behavioral symptoms of dementia. We have to manage the behavioral symptoms of dementia medically more often than not.
Thank you.
There's, of course, the supportive management plays a role, but sometimes medication then comes in place. That medicine is not medicine for dementia. It's actually for the behavioral symptoms. So you're treating the symptom.
Thank you. Ruth, you have something to say?
Yes, I just wanted also to give an input. I'm very happy with the questions, especially that about this person who fears sitting alone in the night, and this one who has a stereotyped type of bringing flowers almost every day. I was happy because the doctor talked about multidisciplinary approach, where we don't just think dementia may just be dementia alone. We have to rule out some other conditions like psychiatric issues, where somebody could just be paranoid about this sitting room. He may feel there are enemies, there are people coming to attack him or her. That's why she or he fears staying alone in that room, and he wants company all the time. Just like the other example, was it Regina who said, or Juliet who said somebody hits tables on the doors, just because this person is afraid, suspicious people are coming to break into the house at night. So we have to rule out also other conditions like psychiatric illnesses and treat, as the doctor has said. Thank you.
Thank you, Ruth. Lisa, JK?
Yes, for me, I just wanted to ask Daktari. So if I suspect my care receiver could be heading towards having that condition, who is the first physician that I take my care receiver to so that a diagnosis can be done? Thank you.
Like I mentioned, ideal situation, your geriatric doctor would be your ideal space to start with. But because we are in a resource limited space, if you have a family doctor, it would be good to start there. And if you still don't feel that is satisfactory, maybe the neurologist or the psychiatrist, either or, would be able to diagnose based on the clinical history they would take. And the reason I shared what kind of history should be taken is in case your doctor is not asking you those questions, please volunteer that information for yourself.
Any other question?
Or there was somebody who said, what happens where somebody refuses to eat. Sometimes low stimulus may be very important, where you may put on low volume music as they eat. That may also distract them from other things and then concentrate more on the food. So low stimulus environment is very important sometimes when you get to dementia patients. Thank you.
Thank you, Ruth. Any other question or any other clarification?
What happens when they oversleep, or sometimes they don't sleep completely the whole night, or sometimes she sleeps like the whole night, the morning up like to 11. What can have happened?
Sir, you have Shege, you have something to say?
Yes, I also wanted to give a brief of my care receiver, because I have taken her to, she has a personal doctor, but I also wanted to find out, are there any geriatric practitioners? Because I think from my experience, like her personal physician is very good, but well, is very good with her, but I would rather see a geriatric, because with our elderly, you know, even how one converses with them is very critical and very key. So do we have any geriatric physicians?
Yeah, yes, Lisa. Are you in Kenya or where are you?
Yes, I'm in Nairobi actually.
You are in Nairobi?
Yes.
The doctor who is doing the presentation, who has just done the presentation, is a geriatric doctor. Geriatric doctors are not in Kenya. We don't have many. We have either one or two, and she's one of them. So look for her with your patient, and I think all will be fine. Look for Dr. Tasneem.
Tasneem.
Tasneem. You will check on us. We shall give you her number so that you look for her. Yes, there she is. Dr.
I'm so sorry.
Go ahead.
Sorry, I got a very urgent call. I might have missed part of the conversation.
Lisa, can you repeat?
Yes, I was just saying, Daktari, that my care receiver is an elderly, my mom actually. She has a personal physician who is very good with her. But from my experience, after taking her to a psychiatrist and these other doctors, you know, even how the interaction with the patient is very key. So I was just asking about a geriatric physician, you know, because I've noted that with the elderly, even the way you converse with them is so important, because if they form an opinion from the word go, they'll not go back there. So that's what I was asking about, a geriatric physician.
Yes, unfortunately, there are far and few of us. I'm one of them. There may be one or two others. I'm happy to help where I can, when I can.
Okay.
So you could get my contacts from Sister. Have my contacts.
All right. Thank you.
Yes, you're welcome.
At the same time, Lisa,
yes,
we have the training for caregivers. The training for caregivers is going on at CASAK. So we really want to bring such people on board like you, so that you get to understand exactly what happens and how it should happen. The doctor has just been explaining, but when you come and sit in class and you get this information, the knowledge, you'll be able to handle your mother. Thank you.
Thank you so much, sister.
You're welcome. Any other person with a question or clarification?
Yeah, you have talked of the training. Is it only for the religious, or even the lay people can get this training to help?
This training is open to everybody. You have just heard what we have heard, what the doctor has explained. We need caregivers so that we take care of our elderly. The training is open.
Okay.
It's for everyone. Get in touch with us.
And at the same time, sorry for talking when we are finishing. One of the elderly member that during the day she is very active, but the whole night she talks throughout. Even the members of the community find it very difficult. And when she is asked, oh, how can we help you? What do you need? She say, was I talking? But when she's in her room, she's just but talking.
Like we had mentioned, the sundowning syndrome. This sounds like a typical sundowning. It's good to get her assessed, get the environment checked, to understand what may be happening to cause this, and then address it thereafter. It's important to find out why.
Crescencia, you've gotten that?
Yes, sister.
Those asking for the details of the training, please get in touch with CASAK. Our administrator will give you all the information about the training, and anything concerning our training, you'll be told. So get in touch with the office of CASAK so that you get to know what is happening and what is taking place when we are talking about the training for caregivers. You have seen what Daktari said. Caregiver training is important so that you get the knowledge on how to handle these people. We'd like to thank Dr. Tasneem for the good presentation and prepare for the next one. After 2 weeks, we shall be getting another one and she'll be on board. So thank you for coming, and we would like to close with the word of prayer. I hope I'm not closing anybody out with the question.
Mine is not a question, it's not an input, but it's just a word of thank you so much for the encouraging information, enriching information. I'm so impressed, and this makes me wish to come to visit that place whenever I come down to Kenya. Thank you so much.
You're most welcome. In the name of the Father, and of the Son, and of the Holy Spirit, amen. God, we thank you for this session that you have given us. Thank you for the opportunity. Thank you for the knowledge that we have received. We pray that this knowledge may help us now and all that we are going to do to our people, so that it may improve the quality of life of our people. We make our prayer through Christ our Lord. Amen. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Thank you.